Recording in progress.
Good morning, everyone, and welcome to our Friday morning meeting. Today, we're going to be speaking about hypoxic ischemic encephalopathy of the newborn. It's quite an intense topic. It's quite a controversial topic with regards to us and litigation, etc. It's also quite a long topic. We're going to try and condense it down to about an hour. I will hand you over to Dr. Raghunandan, and then we will take comments and questions thereafter. Thank you.
Thank you, Dr. Pritipal. Good morning, everyone. So I'm Dr. Raghunandan. I'll be presenting on the topic of understanding hypoxic ischemic encephalopathy of the newborn. My supervisor was initially Dr. Frank and now Dr. Pritipal. So we start by introducing neonatal encephalopathy and the global burden. So neonatal encephalopathy is an altered neurological function in a newborn due to a brain insult or injury. The major cause of death and long-term disability, including epilepsy and cerebral palsy. It's a complex condition with diverse causes, subtypes, and risk factors. And the causes include infections, brain malformations, metabolic disorders, intracranial hemorrhage, hypoxic ischemic events. So hypoxic ischemic encephalopathy is a type of brain injury that occurs when the brain is deprived of oxygen and blood flow during perinatal period, leading to a damage and dysfunction of brain tissue. It is a diagnostic challenge, and until other causes have been ruled out, it can be referred as neonatal encephalopathy due to suspected HIE, also called in short form NESHI. So in terms of global burden, globally, the incidence is approximately 1.2 million cases per year, with 1 to 3 out of 1,000 live births in high-income countries. Sub-Saharan Africa has the highest incidence at approximately 15 per 1,000 live births, and the exact figure in South Africa is unknown and depends on the definition and criteria used. It has been quoted as being somewhere between 1.5 and up to 13.3 per 1,000 live births. So we speak about the significance of HIE. In terms of mortality, 15 to 20% infant mortality in moderate to severe HIE. Morbidity, up to 25% of the survivors have permanent neurological deficit. So this is because cognitive skills development is usually a gradual and dynamic process. The encephalopathy is multifactorial and heterogeneous in nature. After 18 to 24 months of seemingly normal development, psychomotor, cognitive, and behavioral problems may appear as subtle challenges and become even more apparent in adolescence. Neuropsychological assessments at early ages may not be sufficient for detection of long-term consequences. So in terms of pathophysiology, the primary mechanism of HIE-induced injury to the neonatal brain include excitotoxicity, oxidative stress, and inflammation, which collectively contribute to neuronal cell death, either via apoptosis or necrosis. Hypoxia ischemia leads to cascade of events that include acidosis, release of inflammatory mediators, and free radical formation that results in loss of normal cerebral autoregulation and diffuse brain injury. Degree of injury depends on the severity and duration of insult and brain maturation at the time. In term infants, myelinated fibers are more active and therefore more vulnerable to HIE. So this diagram is an overview of the pathophysiological features of HIE. So brain damage after perinatal hypoxia ischemia is a dynamic process that will evolve slowly over time. There are 4 phases of hypoxic ischemic insult. The first one is the primary energy failure, which is the first 30 minutes after the insult. The second one is the latent phase, which is 30 minutes to 6 hours post the first insult. There's a secondary energy failure phase, And there's a tertiary phase where neuronal cell death may continue after 72 hours to months after the initial insult. So primary phase of insult. So usually for the normal brain function, oxygen consumption is 20% of the total body consumption, and glucose is 25% of the total body consumption. The primary insult, there's a reduction in oxygen and glucose supply. There's insufficient production of high energy ATP, which causes energy failure. So this failure of the sodium ATP pump causes membrane depolarization, efflux of potassium, influx of sodium, that give rise to cell swelling and cellular anoxia, cell lysis. There's also neurotransmitter imbalance that is involved. So normally in the developing brain, there's inhibitory neurotransmitters that are predominant and contribute to the exceptional tolerance of the developing brain to hypoxia and ischemia. But in HIE, cell lysis favors the accumulation of excitatory neurotransmitters in the extracellular space. So the latent phase, there's partial or complete recovery of cerebral oxidative mechanism and depends on duration and severity of insult. There's apparent improvement in terms of resolution of cell swelling and reduced level of excitatory neurotransmitters. The key mechanisms of injuries occur are induced at this time, but will only manifest in the secondary stage. Therefore, it is therefore the period that's chosen for therapeutic hypothermia initiation. So in terms of the secondary phase, there's delayed and progressive failure of oxidative metabolism. There's reperfusion, circulates the excitotoxic neurotransmitters to other brain areas, so it increases the injury territory. There's mitochondrial dysfunction, secondary deterioration, so it's the time period when you start seeing seizures. There's also cytotoxic edema and neuroinflammation. And the common endpoint there is cell death via necrosis and apoptosis. And the tertiary phase, it's an ongoing effect on the brain. It's more than 72 hours after the primary insult, and it can last from weeks to years. And it is characterized by impaired endogenous brain plasticity by opposing neuroprotective pathways and pro-repair mechanism. So there's sensitization to inflammation that leads to gliosis. There's increased seizure susceptibility, impaired maturation and myelination of oligodendrocytes, altered proliferation and synaptogenesis, and epigenetic alterations. So neonatal encephalopathy, it's a postnatal diagnosis of disturbed neurological function in newborn. It clinically presents in the first 24 hours of life as neurological and multisystemic changes, variable severity, similarity independent of causative factor. So it has a singular and composite effect as well. In terms of clinical tools for assessing neonatal encephalopathy, it should be done during the first 6 hours of life, and it composes of bedside assessment as well as imaging. So we speak about the SARNAT staging. It's an old staging from 1976, but it's still in use. It's a clinical tool to assess severity of neonatal encephalopathy and provide a clear picture of infants' neurological status. It cannot be applied retrospectively and needs to be performed within the 6 hours of birth. It can be used at discharge to compare neurological status. And it's a qualitative system of staging that involves clinical assessment in terms of level of consciousness, activity, neuromuscular control, which is assessed through tone, posture, and tendon reflex, primitive reflexes of the newborn, so your suck, your moro, and the neck tone, autonomic function as well, so pupils, heart rate, and some modified versions also include respiratory rate, bronchial secretion or salivary secretions, and GI motility. Seizures are also in the criteria, and it also comprises of EEG as well. So the SARNAT staging, it gives you it categorizes the neurological encephalopathy into 3 grades, grade 1, grade 2, and grade 3, which varies in terms of clinical course. So with grade 1, it's fully reversible, and usually within 24 hours it can resolve. With grade 2, the symptoms last 2 to 14 days, but are more common within the first 2 to 14 days. And in grade 3, it is prolonged. In terms of seizure, it's rare in the grade 1, and in the grade 2, it's more common within the first 24 hours. And in grade 3, it may occur early and then cease afterwards, but it actually ceases because there's no functional cortex left to actually generate a seizure. So in terms of degree of care, grade 1, it's minimal and supportive. Grade 2 involves anticonvulsants, supportive care, and cooling therapy as well. And in grade 3, it's going to escalate to ventilation, ICU care, multi-organ support. Cooling therapy has limited benefit in that case. So on the short term, they'll be able to, in the grade 1, they'll be able to feed normally, and the behavior will be normal within 24 hours. Grade 2, the recovery can take several days, and there might be transient feeding and tone abnormalities. And in grade 3, there's a prolonged coma and there's a risk of neonatal death. And in terms of long-term neurodevelopment, in grade 1, it's normal. In grade 2, there's 20 to 30% that are going to develop motor or cognitive deficits and mild cerebral palsy, learning delays as well. And in grade 3, there's a more than 90% risk of severe neurological disability. In terms of EEG, so we see with the grade 3, you have more severely abnormal patterns on the EEG. And in terms of the MRI, in grade 1, it could be normal, or we could see mild or white matter changes. Whereas in grade 2, you start having basal ganglia, thalamic, or watershed injury pattern. And in grade 3, it can be a diffuse cortical injury pattern. And in terms of the mortality, with grade 1 encephalopathy, there's less than 1% mortality. With grade 2, it's 10 to 20%, and with grade 3, it's 50 to 80%. So this is the neonatal encephalopathy score sheet that is used in the province. It has both the SONAT staging as well as the Thompson score. And in practice, they tend to favor the Thompson score. So the Thompson score is it's a quantitative scoring system. It's based solely on clinical assessment of the neonate. It is suitable in low resource setting. It's a serial scoring system, so it can be used to track evolution of neurological status. And it has a scale from 0 to 22. So mild is a score of 0 to 10, moderate is from 11 to 14, and severe would be more or equal 15. So it assesses the tone, the level of consciousness, seizures, posture, Moro, grasp, suck, and respiration, and the fontanelle as well. So what are some of the diagnostic challenges when we speak about HIE as a cause of neonatal encephalopathy? So first of all, it's a postnatal diagnosis, and it's an evolving diagnosis and presentation, and it presents similarly independent of other causes. There's also a variation in diagnostic criteria. Most global consensus groups and randomized control trial agree that a cord or early neonatal pH of 7 or less, or a base deficit of 16, could be used to make the diagnosis. In other ways of other consensus, less acidosis, plus minus additional criteria, example, the need for resuscitation, and intrapartum events that were present are also in the diagnosis criteria. Some babies with HIE have normal cord gas, and acidosis may result from other factors, such as delayed clamping. Neonatal encephalopathy can result from multiple other causes, regardless of the presence of acute hypoxia ischemia, and many of which are not identifiable soon after birth. Timing of insults is difficult to determine as there can be an overlap. And in terms of imaging, while EEG is valuable to assess seizures and encephalopathy, it is not specific to HIE and requires expertise for interpretation. MRI is the most sensitive but not readily available. It has evolving image patterns and changes may not appear until a few days. So why is it important to know that HIE is actually the cause of the encephalopathy? So the first thing is for early and appropriate treatment initiation for a better outcome. So therapeutic hypothermia needs to be initiated within the first 6 hours of birth. Other causes such as infection needs to be addressed as early as possible. So initiation of antibiotics and septic workup. And metabolic abnormalities need to be corrected early as well. In terms of other importance is parental counseling and prognosis. So escalation of care, they need to be aware about potential escalation of care and follow-up adherence. That is going to improve follow-up adherence as well. Realistic expectation and long-term implication and the possibility of prolonged hospital stay. Medico-legal implications. So litigation regarding intrapartum care, intrapartum hypoxia versus antenatal hypoxia versus postnatal hypoxia, determining the degree of contribution of the acute intrapartum event to the overall HIE presentation. Neonatal encephalopathy, a cause is often unknown. Sentinel hypoxic event is infrequently present despite fetal acidosis and all low Apgar scores. And the last thing is auditing for improved practice. So it's important to identify antepartum risk factors for better optimization, intrapartum care and fetal monitoring, improvement of prevention strategies and early recognition. So there is currently a terminology shift towards the use of neonatal encephalopathy from suspected hypoxic ischemic encephalopathy instead of HIE. So the term NESHI acknowledges that encephalopathy could be due to other mechanisms than hypoxia, despite evidence of intrapartum hypoxia. And it also encourages investigation for alternative cause. It acknowledges overlap contribution, widens the treatment options, which become more comprehensive for a better outcome. Neonatal encephalopathy, in terms of NESHI, so it's also a medical legal aspect in terms of documentation of the HIE. So when it's documented as HIE, it could be interpreted as proof of intrapartum asphyxia, implying a possible preventable obstetric error. NESHI acknowledges suspicion while accommodating for diagnostic challenges and diagnosis uncertainty. So this is the criteria used by ACOG for HIE. So it requires all 4 of the following, which is umbilical cord or early neonatal gas pH of less than 7, or a base deficit of more or equal to 12, early onset moderate to severe neonatal encephalopathy, cerebral palsy of spastic, quadriplegic, or dyskinetic type, and exclusion of other causes, which is infection, trauma, and metabolic. And it also includes supportive criteria like the presence of a sentinel hypoxic event, which could be an abruptio, a rupture, a cord prolapse, abnormal CTG, imaging patterns of hypoxic ischemic brain injury, Apgars of 0 to 3 for more than 5 minutes, and evidence of multi-organ dysfunction. This criteria applies to term and near-term infants that they define as more than 34 weeks, because before 34 weeks, it is thought that the pathophysiology behind the encephalopathy would be more likely multifactorial. So this is the checklist used in UKZN to assess neonatal encephalopathy in terms of causative suspicion. So if we look at the first part, it's specific to hypoxic ischemic encephalopathy. So they look into the history, which is poor maternal weight gain, presence of maternal infections, acute sentinel event, hypertension, chorioamnionitis, fetal distress, any CPD, any nuchal cord. And they assess for IUGR, hypoxia, ABGAS of less than 7 at 5 minutes, any signs of cardiac arrest, early encephalopathy, and multi-organ involvement. And in terms of investigation, it's the blood gas, so your pH of less than 7, your base deficit of more than 12, urine or blood or protein in the urine, and a troponin level that's high. So this slide is on a retrospective record review of infants admitted with HIE that completed cooling therapy from January 2018 to August 2019 at a neonatal unit in Tembisa Provincial Tertiary Hospital in Gauteng. It included its participants included 93 infants that were classified by Thomson score as mild. There were 32 in the mild group, 48 in the moderate group, and 13 in the severe group. So they found that maternal factors that were associated with HIE, hypertension was noted in 11.3% of the cases. Perinatal risk factors, the first one was meconium aspiration at 50.5%. And the second one was prolonged second stage of labor at 17.2%. And with cases where who had severe Thomson score, prolonged resuscitation of more than 10 minutes, a need for they had a prolonged resuscitation for more than 10 minutes. They had a need for adrenaline. They had a low pH, high base deficit, and a median length of stay of 7, 8, 9 days for mild, moderate, and severe, respectively. And there was a need for anti-seizure medication on discharge, more so associated in the severe HIE group. So in terms of cord blood, during labor, the fetal circulation is centralized, favoring oxygen distribution to fetal brain, heart, adrenals, with lower oxygen levels in peripheral tissue. So arterial blood better represents the fetus, and venous blood, the base deficit overestimates the metabolic component of fetal acidosis. So ideally, 2 samples should be taken, one arterial, one venous, to help validate the arterial origin. It should be taken within seconds after birth. Acidic metabolites accumulated in the fetal peripheral tissues tend to flood back into circulation and into the cord artery as the newborn starts to breathe, moves, and cries. So the pH is going to go down and the lactate is going to go up. So earlier recognition for cord gas was selective. So cord gas used to be taken only in preterm labor, meconium stain liquor, assisted emergency deliveries, vaginal breech delivery, shoulder dystocia, intrapartum fever, maternal thyroid diseases, multiple pregnancies, growth restriction, SGA, intrapartum hemorrhage, fetal distresses, among others. And it's now the recommendation from SASOG has now moved to the need for routine cord blood gas for all vaginal birth, all emergency cesarean sections, and all compromised pregnancies, even if delivered by elective Caesar, as umbilical cord gas sampling is the most effective determinant of the fetal metabolic condition at birth. So in terms of how to do the cord blood sampling, immediately after birth, and it should be both arterial and venous cord blood, unclamped pulsating cord sampling allows beneficial effects of placental transfusion occurring with delayed cord clamping. If baby needs immediate pediatric care, then you can milk the cord 3 times, 10 centimeters of it towards the infant. Delayed cord clamping for all, unless require immediate attention. And the midwife needs to ensure lab collects sample promptly and run sample at nearest blood gas machine. Abnormal results. For any abnormal results, you need to make detailed case notes inform pediatrician immediately of all abnormal results to escalate care, and to consider MRI brain to identify possible intrapartum hypoxia. And the placenta needs to be sent for histology as well. So ACOG's statement regarding cord blood, an abnormal pH at birth does not provide assurance of timing of fetal neurological injury. Brain injury due to HIE is very unlikely when 5 minutes Apgar is more than 7 and the umbilical arterial cord pH is more than 7.2. HIE is progressively more likely to occur with increasing acidemia. So the role of imaging, so EEG, as we said, is non-specific. It can only help detect moderate encephalopathy within 6 hours and seizures. But an abnormal EEG at 48 hours is associated with neurodisability and mortality. Cranial ultrasound does not have a role in HIE per se. It's more for screening intracranial hemorrhage and hydrocephalus. So MRI is the one that gives HIE specific patterns. So in terms of MRI, recommended neuroimaging modality for infants with neonatal encephalopathy. The pattern of brain injury gives an insight on the mechanism of injury and severity. It also helps in etiologic diagnosis and excluding other causes of neonatal encephalopathy. It helps in terms of prognostic purposes, correlation with neurodevelopmental outcome. It's not readily available and it requires expertise. There's logistics involved in terms of sedating the fetus and monitoring the fetus while doing that MRI. And an absence of brain injury on MRI does not completely exclude hypoxia ischemia as a cause of neonatal encephalopathy. But MRI remains the most closely aligned with histopathological findings of HIE. And there's a need for a standardized imaging protocol when speaking about HIE. So in terms of the findings, they evolve over hours and days. The timing of scan, if it's too early, it's going to underestimate the injury. The optimal window would be 3 to 5 days, and after 7 days, there's pseudo-normalization of the diffusion changes. Restricted diffusion patterns seen earlier may resolve even though the tissue injury is permanent. Later imaging will show evidence of injury in terms of gliosis and atrophy, but will be less distinct for acute ischemic pattern. And with the use of hypothermia therapy now for HIE, there's a tendency to shift the optimal timing for MRI towards 4 to 6 days so as to balance sensitivity and specificity for detecting hypoxic lesions in cooled infants. So this diagram is a representation of some of the MRI changes that are commonly seen in HIE. So the first The second one is basal ganglia and thalamic injury. And the third one, it's a diffuse pattern injury near to central basal ganglia thalamus pattern. It may extend to the cerebral cortex as well, and it is and also cerebrocortical deep nuclear pattern. It's usually bilateral and symmetric. It often follows a perinatal sentinel event, a moderate to severe, relatively prolonged insult. Experimental studies have shown the possible combination of a near to total asphyxia and partial asphyxia as a single event or across serial events. Watershed injury pattern, it's parasagittal cerebral cortex subadjacent white matter along the vascular border zone. Bilateral, may be asymmetric, more commonly localized to posterior parietal occipital regions. In terms of the neuropathology, it's selective neuronal necrosis, and the pattern is actually associated with higher survival. It's most likely secondary to prolonged maternal hypotension, hypoglycemia, or sepsis. In terms of global injury pattern, There's a widespread neuronal necrosis across essentially all levels of the neuraxis, so cortex, deep nuclear gray, midbrain and brainstem. Diffuse signal abnormalities. Cerebellum may appear relatively normal, however, quantitative imaging metrics may be abnormal. Most severe clinically, and it is associated with very severe and prolonged insults, and experimentally with prolonged asphyxia. So in terms of the biomarkers for fetal hypoxia, we know that when there's hypoxia, there's an increased transcription of the erythropoietin gene, which leads to erythropoietin synthesis within the first 90 minutes and a rise in the EPO level between 1 and 4 hours. Presence of nucleated red blood cell in circulation within 24 to 36 hours. It gives us a glimpse into the time frame of when the hypoxic event occurred, and it could be a proxy for fetal hypoxia. Magnitude of increase is related to the severity and duration of that hypoxia. The drawback is that there is a degree of overlap in terms of chronic, subacute, and acute hypoxic trigger. So the S100B, it's a biological brain-specific cell injury marker in astrocyte and Schwann cells. It's a marker of neuronal injury that is released and detectable in urine, amniotic fluid, blood, and CSF. And its concentration correlates with severity of encephalopathy as well. So during pathophysiologic stages of HIE, there is reactive oxygen species and reactive nitrogen species that are released. To counteract this, there are specific antioxidant enzymes that are also released as a protective mechanism. And these specific antioxidants found in the cord blood could potentially be used to correlate with fetal hypoxia. So examples of them are superoxide dismutase and glutathione peroxidase, which positively relate to HIE stages. And the isopropane 8 and the PGF2 alpha, which relates to the severity of perinatal asphyxia. However, small and heterogeneous studies and lack of reference standards have so far hindered the clinical validation of these markers. So how do we approach HIE management? So there's 3 aspects to it. There's the labor and delivery. There's the immediate post-birth and the early neonatal period, which is more for the neonatal side. Labor. So when the patient comes in labor, we need to anticipate the risk in terms of risk of sentinel events, abruptio, cord prolapse, risk for rupture, maternal collapse as well. We need to recognize abnormal fetal heart pattern, importance and implications of a meconium stain liker, and prolonged second stage. So rapid decision-making, expediting delivery, communication with the pediatrician to be present at birth to attend the infant, cord blood, placenta and histology, for histology, documentation and counseling. Immediate post-birth, the goal would be to establish breathing, circulation, and oxygenation. So suction, if any, obstruction or meconium under direct vision. Assess the ventilation needs. Positive pressure ventilation within 1 minute if Apgars are less than 5, or fetus is gasping or apneic, and maintain saturation of 90 to 95%. In terms of circulation, chest compressions need to be initiated after 30 seconds of effective positive pressure ventilation if the heart rate still remains below 60, and the additional use of volume expanders and inotropes. And in the early neonatal period, so it's maintenance of airway, breathing, circulation, glucose, temperature, fluids, urine output, early neurological assessment so that they can start the hypothermia therapy when it should, anti-seizure treatment, and imaging as well. So in terms of management, we'll speak a bit about the cooling therapy. So cooling therapy is the standard of care for neonates with moderate or severe NESHI and who are more than 36 weeks. So the core body temperature is reduced to 33.5 degrees for 72 hours and that provides neuroprotective benefits. It significantly improves the survival without disability, and this benefit has shown to persist for up to 6 to 7 years. Reduces the combined risk of death and severe disability at 18 months by 12 to 15%, and effectiveness for neonatal encephalopathy due to other causes in preterm or if initiated after latent phase is unproven. So this is a study that was done. It's called the Toby trial. So it was a study done for a multi-center randomized control study, whole body in infants, 325 infants who had whole body hypothermia for HIE, and there was 163 in the cooled group versus 162 in the control group. Rectal temperature was maintained at between 33 and 34 degrees for 72 hours. So the findings were a combined risk of death and severe neurodevelopmental disability of at 18 months of 52% in the cooled infants versus 66% in the control infant. Relative risk of 0.77, confidence interval of 0.65 and between 0.65 and 0.92, and a p-value of 0.02. When they spoke about severe neurodevelopmental disability, so they took into consideration the Bayley Mental Developmental Scale, but also gross motor function as well as bilateral cortical visual impairment. And the second finding was severe disability, 21% in the pooled group versus 39% in the control group, with a p-value of 0.03. So this is a diagram of what is used in KZN for eligibility for hypothermia therapy. So the first 4 criteria, they all have to be present. So it has to be gestational age above 36, birth weight of more than 1,800 grams, age of less than or equal to 6 hours, and transport needs to be available to reach the referral center within 6 hours of birth. And any one of the next criteria, so 10-minute APGAR score of 5 or less, pH of less than 7, base deficit of more or equal to 12, abnormal EEG, 10 or more minutes of assisted ventilation at birth, and a Thompson score of 7 or more within the first 6 hours of life. So we speak about the long-term outcomes of HIE. So there is a systematic review of 7 studies done in USA, UK, Italy, Brazil, and China that assess for the incidence of cognitive function after the infants had hypothermia therapy for HIE. So there were 521 participants in total, and it found that even with extensive use of cooling therapy, many infants will go on and experience neurodevelopmental deficits, more so with severe cases of HIE. There's a high risk for neurodevelopmental complications, even in absence of MRI abnormalities. So this table represents the findings from this study. So if we look at 1, 2, 3, 4, 5, we look at the 5th line. It's the one that had the highest GBI score. GBI score is a tool used to evaluate the quality of the study. So from that one, it suggested that children with neonatal HIE typically have delayed language skills, with the evidence increasing with age. And if we look at the other study findings, we had a GBI score that was found to be moderate. So whole brain gray and white matter volumes are lower in children who experience therapeutic hypothermia. Even in absence of MRI abnormalities, newborns with significant HIE are at high risk for neurodevelopmental sequelae, such as poor performance score and hearing language score. And also, there was a significant correlation that was found between childhood impairment and poor independent function in children with HIE, as reported by their parents at 18 months of age. And the last one, emotional processing, sensory movement, cognitive function, learning, and memory. Neonates with moderate to severe HIE were found to have a lag behind those compared to those who only had mild HIE. So in terms of long-term implication, susceptibility for cognition, memory, executive dysfunction, even if motor deficits are absent, it is crucial to monitor intellectual development after infancy. Dysfunction can be subtle, if any, in early years and manifest later as behavioral adjustment difficulties and learning disabilities. Children with watershed injuries on brain MRIs, close monitoring of cognitive function, particularly language development. Long-term follow-up research is needed to ascertain if those cognitive dysfunction actually continues throughout adolescence and later in life. So this shows it's a retrospective study, 20-year birth cohort study that included more than 300,000 newborns. It included the admission CTG and the intrapartum CTG trace from spontaneous singleton term pregnancies in 7 maternities in Finland between 2005 and 2024. So newborns with HIE were following intrapartum asphyxia were identified by a normal CTG at admission, whereas antepartum exposure was indicated by an abnormal admission CTG. So we found that there was 141 normal admission CTG. Out of those, 71 cases had a sentinel event and timely delivery. And those, if we excluded those, there were 70 cases that remain in which hypoxic encephalopathy presumably developed during labor and was considered potentially avoidable. So that would actually represent 22% of the overall HIE cases. So the findings were half of the cases of intrapartum HIE with normal admission CTG was potentially avoidable, suggesting that, as we said, 1/5 of all cases, whether it's acute, subacute, or chronic, could have benefited from preventive measures. These findings underscore the role of optimal intrapartum care in preventing HIE. So what would be the prevention strategy? It's 3-component oriented. So one is identifying the patient and fetus at risk. Second is monitoring, and the third is labor and delivery. So identifying risk factors, so maternal risk factors, hypertensive disorders, preeclamptic patients, diabetic patients, patient with severe anemia, sepsis, autoimmune diseases such as SLE, and renal chronic kidney disease as well. In terms of the placental, any abruptio previa, uteroplacental insufficiency, or vasa previa. And in terms of the fetus, any evidence of growth restriction or complicated pregnancies, such as TTTS or any complication of multiple gestations. Identifying risk factors, so it is important to understand the difference between a priming and a sentinel event. So a priming event is an antenatal risk factor that would increase susceptibility of that fetus to the primary insult. So it could be chorioamnionitis or any early infections, placental insufficiency with hypertensive disorders, diabetes, smoking. In terms of the placenta, it could be abnormal insertion or a mature placenta. In terms of sentinel event, that would be an abruptio, a prolapse, meconium aspiration, or a true cord knot. So it's any sudden, severe, and unexpected, and often unpredictable cause of profound fetal hypoxia. So the best way to monitor fetus in labor for low-risk patients is intermittent auscultation has been shown to give the best outcomes. However, it is labor intensive. CTG monitoring in labor in low-risk women often leads to unnecessary intervention and increased seizure risk by up to 30% without an improvement in neonatal outcome, but an increase in maternal morbidity and possibly mortality. So there's a recent meta-analysis by Tom et al. That looked at admission CTG in low-risk pregnancies, and we'll give a brief summary of that in the next slide. So admission CTG typically involves a 15 to 20 minute recording that combines fetal heart rate and uterine activity. So this systematic review and meta-analysis looked at about 16,000 women to evaluate the effect of admission CTG compared with intermittent auscultation upon admission and compared the various outcomes. So the findings were no significant difference were found for seizure, fetal blood sampling, instrumental deliveries, and neonatal intensive care unit admission. So there was no role for admission CTG in low-risk women. Electronic fetal monitoring was introduced in obstetric practice in 1960s as a tool to identify early deterioration of fetal acid-base balance, with the expectation that prompt intervention could would reduce neonatal morbidity and mortality. So CTG has not seemed to reduce the overall incidence of permanent intrapartum linked neurological injury, although it may have lowered the incidence of neonatal HIE and seizures. It does not reliably identify or predict fetal acidosis, and it has a poor, which means it has a poor correlation with early fetal acidemia. So subjective interpretation and poor intra-inter-observer agreement, and a normal CTG has high sensitivity and a low specificity. So how do we use CTG effectively to improve the perinatal outcomes? So fetal heart rate pattern, interpreted in clinical context, gives information on fetal neurological integrity. It gives insight into mechanism and evolution of hypoxic or ischemic threat. And a normal CTG tracing at the onset of labor implies a neurological integrity and the absence of any hypoxic or ischemic threat. Standardized interpretation of a CTG improves subjective interpretation and poor intra-inter-observer agreement and allows for clarity in terms of next action to be taken. When we look at a CTG, we need to decide whether the CTG features are reassuring, non-reassuring, or abnormal. So this is actually from the National Integrated Maternity and Perinatal Care Guidelines of last year. So it categorizes the CTG into reassuring, non-reassuring, and abnormal based on baseline, variability, and deceleration. So as we know, reassuring would be a baseline between 110 and 160, variability of between 5 and 25, and deceleration not present or only early deceleration. Non-reassuring is a baseline between 100 and 109 or 161 to 180. Variability of less than 5 beats per minute, but for less than 50 minutes, and variable decelerations without concerning features. And in terms of what we would categorize as abnormal, it would be baseline of more than 100 for 5 minutes, greater than 180, variability reduced by 5 beats per minute for more than 50 minutes, or a sinusoidal pattern. And in terms of deceleration, it would be variable deceleration with concerning features, late deceleration, or a single prolonged deceleration lasting for more than 3 minutes. So when we speak about concerning features, it would be reduced variability within the deceleration, failure or slow return to baseline fetal heart rate after the end of the contraction, a loss of pre and post deceleration shouldering, and lasting for more than 60 seconds. So all of us need to use the same terms when categorizing CTG avoid the terms reactive and non-reactive, use normal, suspicious, and pathological. Once the CTG has been categorized, we need to decide on whether the fetus is compromised or not, and what further action needs to be taken along with urgency of the action. So as we can see, for example, in the pathological category, immediate management would be stop induction, augmentation, tocilize, change position, or deliver, depending on the clinical context. So what is not recommended? So there's the Cochrane systematic review from 2007, 2013, and 2017 that concluded that fetal scalp blood sampling did not improve long-term perinatal outcomes or reduce intrapartum operative interventions, but actually increased seizure by up to 60%. A recent systematic review and meta-analysis, which had included all 9 randomized control trials on fetal ST analyzer and has questioned its usefulness in reducing intrapartum operative intervention. More studies are needed to see if perinatal outcomes improve with the fetal ST analyzer. So in terms of maternal fluids, they should only be administered to correct abnormalities in the maternal circulation, which would be dehydration, hypotension, sepsis. And excess fluids may actually lead to fluid overload in patient and convulsions later in the neonate. In terms of oxygenation, it has been discontinued in clinical practice for several years now as the potential risk outweigh the harm. So there is also a role in looking beyond the standard CTG interpretation of baseline variability, acceleration and deceleration, and into the fetal heart rate pattern, and also on how fetal heart rate pattern for that specific fetus evolved compared to his own fetal heart rate pattern on admission. So we'll look a bit about the features of chronic hypoxia. So there's going to be fixed invariable fetal heart rate pattern, repetitive shallow decelerations, and reduced baseline heart rate variability. It implies a reduced reserve in the fetus, static encephalopathy, increased susceptibility to hypoxic injury in labor, and intrapartum intervention cannot modify the hypoxia. Low threshold, and it should be a low threshold for cesarean section. In terms of acute hypoxia, so it would be a sudden cessation of oxygen, so abrupt shock, cold prolapse, uterine rupture, maternal hypotension, hyperstimulation. So what happens is the fetus attempts to drop its own heart rate and sustain it for more than 3 minutes to decrease myocardial demands and prevent myocardial hypoxia and acidosis. The pH actually drops by 0.01 per minute during that deceleration. And it results in anaerobic metabolism, lactic acid buildup in the myocardium, and resultant terminal failure. Subacute hypoxia, recurrent deceleration, most commonly uterine hyperstimulation, maternal pushing, a short baseline duration prior to the next deceleration, insufficient time to clear accumulated carbon dioxide, initial respiratory acidosis, and then subsequent metabolic acidosis. The decline in pH is 0.01 every 2 to 4 minutes, and there's a loss of vascular tone, depressed myocardial function, and hypotension that brings about the ischemic brain injury. So this is among the patterns that call for action, which means stopping the oxytocin, removing prostaglandin, stop maternal active pushing efforts, avoid supine position, IV fluids if the patient is hypotensive, tocilize if hyperstimulated, expedite delivery if hypoxia persists despite the tocolysis. And gradual evolving hypoxia. So the deceleration occurs as a cardioprotective reflex to avoid anaerobic metabolism when oxygen supply is being intermittently interrupted. So there is loss of acceleration, which is seen because of restriction of the fetal body movements, so as it tries to conserve oxygen and nutrients. There's increase in baseline secondary to catecholamine release. The aim is to increase heart rate to obtain more oxygen and nutrients and maintain perfusion of central organs. So it becomes decompensated when there's an unstable baseline fetal heart rate, which symbolizes anaerobic metabolism, and abnormal variability, which symbolizes instability of the autonomic nervous system. So we'll speak a bit about the medico-legal aspect. HIE is every obstetrician nightmare due to the high rate of litigation, which is increasing every day. More than 50% of medical legal claims in 6 out of 9 provinces in South Africa is cerebral palsy related, which is costing the state billions of rands. What is not in our favor is the aggressive lawyers that make the benefit of large payouts enticing to patients who may not even have had HIE. This has all led to an increase in insurance premiums for doctors practicing obstetrics, with costs on the rise every year. What we need to do is improve overall care and reduce incidence of NASHI to help reduce claims. The cornerstone of doing this is meticulous documentation and thorough counseling of the patient. So we look at a publication in the South African Medical Journal, Saturday Supplement, was published in 2021. It looked at 10 criteria in implicating intrapartum hypoxia in HIE or cerebral palsy claims. It acknowledged pitfalls with clinical notes and Apgar scores and cold gases in state. So criteria that they used to implicate intrapartum hypoxia in neonatal encephalopathy. So for case definition, they define neonatal encephalopathy syndrome as disturbed neurological function in the earliest days of life, an infant born at more or equal to 35 weeks and manifested by subnormal level of consciousness or seizures. It also involved the Apgar score, umbilical cord artery pH, multi-system organ failure involvement, type and timing of contributing factors that are consistent with a peripartum or intrapartum event, fetal heart rate monitor pattern consistent with a peripartum or intrapartum event, neuroimaging in terms of MRI, and no evidence of other proximal or distal factors that could be contributing factors. Developmental outcome in terms of spastic, quadriplegic, or dyskinetic CP, and placental histology where available should be interpreted in the clinical context. So in terms of the future work, appropriate fetal maternal monitoring is essential for clinicians to respond timely to potential risk while avoid unnecessary interventions. CTG is a widely used fetal monitoring method. However, CTG has not yet demonstrated a significant reduction in neonatal death or long-term neurological injury, while its association with increased cesarean rates has raised concerns. Fetal monitoring is an important public health priority. Achieving this goal requires a multidisciplinary integrated approach with both technical and clinical solutions. This will involve clinical solutions coupled with electronic solutions, and most likely we are looking at an integration of software such as artificial intelligence in the future. So in terms of therapy, so adjunct neuroprotective therapy. So these are drugs that may promote pro-repair activation, neuroprotection, over protracted pro-inflammatory activation of the microglia. Some of the work being done is on pioglitazone, metformin, and resveratrol, and they look into their role in improving long-term neurodevelopmental outcomes. There's also some work being done on trophic factors, which could potentially boost endogenous repair mechanisms such as neurogenesis and oligodendrogenesis that are stimulated after experimental HIE. In terms of cell therapies, mesenchymal stem cells administered intranasally appear to be promising tools to enhance brain plasticity. So in terms of imaging, timing, modalities, interpretation, correlation with outcome. Some work is being done in the genetic field as well. So pro-inflammatory variants and their degree of involvement in neuronal injury. Genetic variants in receptors that would affect excitotoxicity and apoptosis. Genetic differences that influence the fetus response to the adjunct therapy. And different HIE endotypes where in some babies inflammation so also in future work, translational research is needed, which would bridge preclinical findings to clinical trials and subsequently clinical practice. Training is important for early detection by role of biomarkers, prognostication tools, and imaging. Research by identify impact that would have a maximum clinical impact. In terms of implementation, ensuring access and feasibility for effective management and safety, distribution of care, sustainability, long-term follow-up, and cost implication. So take-home message, we need to look beyond traditional CTG interpretation towards integrated fetal heart rate pattern changes. Acute hypoxic events should come to our mind when we see cord prolapse, rupture, abruptio, severe maternal collapse, and it should equal to rapid action decision to delivery interval with the aim of delivering within 30 minutes. We need to avoid uterine tachysystole, consider prolonged second stage in all its entirety and what it means, and do not delay decision making. Alert neonatal team, and in terms of NESHI, we need to document CTG sized interpretation, APGARs, cord gas, resuscitation steps, and placenta for histology, and very importantly, counseling. That's all. Thank you.
Thanks, Dr. Raghunandan. That was a very thorough, intense talk. I think it covered quite a lot. We tried to fit in as much as possible without having it being an information overload. The main things is as much as we try to avoid HIE or NESHI, as we say, we're still having an issue when it comes to litigation and when it comes to neonatal outcomes. What's worrying is that there's a poor correlation actually between whatever we've done so far and what actually happens with the babies. If you have a look at it, 10% of CP babies can be due to an intrapartum or event. Most of it is actually due to something that happens antenatally. So it's only between 10 and 14%. And there's even babies with poor cord gases may not end up with CP. So it's very confounding. There's too many factors, but we still have a lot of work to do. I will take some questions or comments. Dr. Moran?
Okay, just a couple of different issues. Firstly, you talked about this whole body cooling for cases of NESHI. So a general principle of neonatal resuscitation is that you must warm the baby and you must never let the baby get cold. That's a general principle that is always taught in the resuscitation of the baby. But now, it looks like, well, these sick babies, one is going to cool them for 3 days or something. So you showed one study where benefits were recorded. I think it was the Toby study. I think all the studies have been done in well-resourced countries. There was a big trial done in India. It was in India or Bangladesh for this neonatal cooling for HIE, and it showed worse outcomes for the baby compared to not doing it. So in the South African setting, I think most of the neonatal sort of tertiary units are now doing this whole body cooling. Has anyone actually done a trial in the South African setting to show improved outcomes? Or are they just assuming because it seems to work in well-resourced countries that it must also work here? So that's my first question. Then the second one is maybe according to what you were saying just now. You know, even in well-resourced countries, the rate of cerebral palsy hasn't changed over the last 40 years or whatever, despite the seizure rate going up extremely by many degrees, you know, from 15% or 10% to 40% and so on. So despite that increase in seizure, there's no difference in the prevalence or incidence of cerebral palsy, which I think is just evidence that cerebral palsy is mainly not related to labor. Because if it was mainly related to labor, then greatly increasing your seizure will surely decrease the cerebral palsy. So what I want to know is, has anyone done a case series of cerebral palsy after elective seizure and looked at what the features are of those cerebral palsy cases? Because it's not just cases after prolonged labor. Even after elective seizure, you can get cerebral palsy. So I would have thought it would be interesting to look at those cases and say, these are the features that we see, MRI, etc., etc. And then if we get cases which have similar features, we can say, well, these are the same features that you'll see after elective seizure, and that would maybe help to explain that it may not have been related to labor.
So through the research I did to prepare the presentation, I did come across these different lines of thinking in terms of the use of chorotherapy for HIE infants. South Africa is actually among the countries where the researchers were actually in favor of the hypothermia. So it's actually one of the countries where hypothermia is being used in practice. The studies, I think, were mostly done in Pretoria, if I remember correctly, but I didn't include any of them in the presentation. Regarding the any studies on outcome of CP versus cesarean section, I didn't come across anything that was broadly done comparing that might maybe point us towards whether it would be actually whether there's any actual changes in terms of if we had done an elective or not. And as you rightly said, there is no difference in terms of the CP outcome, it seems, despite the cesarean delivery rate that has come up. And that sort of highlights the role of the chronic hypoxia and priming events that occur antenatally that already puts that fetus in a oxygen reserve condition and already predispose the brain to that neonatal encephalopathy.
Thank you. Any other questions or comments? Yes, Dr. Mason.
Yeah, I think as complex as it is, the issue for any one of us is to be able to show that in our management, once the patient came in contact with us, there were no substandard areas of management. That's the critical aspect in terms of that. So obviously, we can do whatever we do, and damage could already be done. But where the difficulty comes in is when there's delay in action being taken, even if the damage was already done. For example, you've got a CTG or whatever the thing that you're looking at with severe abnormalities, but the appropriate action is taken too late in terms of that. Even if we took it early, the outcome would still be the same, but it's the substandard issue that people point at in terms of the story. So I think we're not very likely going to be able to reduce the CP rate, but we're likely to possibly mitigate the blaming story towards the obstetrician in terms of what really happened, as long as if we take action timeously in terms of that. I obviously were in the presence of the acting HOD of health, and she said she's extremely concerned because the piles of files that are in her office with relate to this CP and the HIE stories, most of it seems to be pointing towards substandard care once the patient has reached an institution. And that's the biggest concern. I was saying to you, no, most of them arrive with abnormal CTGs and whatever, and also, no, that's not really the true story that Mai said. The story is that quite a significant number of them, the substandard areas are occurring when the patient is already in our whatever institutions that you're talking about. So I think our main thrust, having understood that things could have happened before the patient arrived, or things could have been antenatal, is to say the management was standard management. Nobody can fault anybody. The management was standard management. But once it's substandard, we will have difficulty in terms of. Now, obviously, one of the things that was mentioned here is oxygen. That oxygen has now been abandoned as part of the interpartum resuscitation. But you go to our institution, oxygen is still being used liberally. And you say to yourself, the guiding principle, where are they? The protocols, where are they in terms of that? We just seem to be clutching on certain things that don't have, clinical significance, but they might have statistical significance in terms of that. But things that have obviously statistical and clinical significance, we don't seem to implement them. But we are quick to implement statistical significant things that have no clinical relevance in terms of that. That's a classical example of oxygen. It's still being used. Classical example of patient being flooded with fluids. It's still being used. And you're asking yourself, where is the protocols and guidelines that deals with evidence-based medicine in terms of what we're dealing with in terms of that? So I think for me, the take-home message is, let's make sure that from our point of view, standard management is what we offer. And anything else, obviously, can be open to debate. But if it's substandard, there is no way of obviously being able to defend yourself when obviously your fingers are pointing towards you. And I spoke to quite a number of pediatrician neonatologists who are involved in litigation. And one of those who has been involved, he just retired from these litigations, is Dr. Bolther, based at Westfield. He's an expert in this area, and says often the problem might not be what the obstetrician did, but might be what the pediatrician did when they received the baby. But the pediatrician will never say it is what they did. They'll always shift the blame towards the obstetrician. So the only way to mitigate shifting the blame to us is for our management to be standard. Once it's substandard, you have difficulty in being able to say yeah or nay in terms of what you say.
Yeah, thanks, Dr. Maise. I agree with you. We need to follow the standard of care. We need to have protocols, follow protocols that are out there. And very important part of it is documentation. Our documentation has consistently gotten us into trouble in the courts. Poor documentation is one of the main reasons that obstetricians are getting litigated. And it comes from all sides, whether it's obstetrician, whether it's a midwife, whoever's involved in the care of the patient. So we need to document things properly. And if we're deviating from standards, we need to actually document why we've deviated from the standard or not. And another important part is counseling that also lands us into trouble. We don't speak to the mother, and you see a lot of people are afraid to go and speak to the mom once there's an adverse event. And it has been proven over and over again that if you speak to the mom appropriately and if you speak to them and play open cards with them, your chance of litigation is reduced if you're just honest with your patient and counsel her properly. Just talk about that?
Yeah, just on that point of standard care. So as was mentioned, for a low-risk patient, CTG is not standard of care. But in hospitals or even clinics where they have CTG, they will still do CTG on every patient. And that can get you into trouble. Standard of care is monitoring the fetal heart rate every half an hour during the active phase of labor and documenting it. So if you've done that and it was normal and you've documented it, that can be defended in the court of law. Because often the argument, I've been involved in many cases, litigation cases. Often the argument is that there must have been fetal distress. There must have been. It's just that there was no CTG, so it was missed. It's speculation. But if you documented the fetal heart rate on the partogram, there is evidence that it was normal, and you can defend that. Of course, if it was a high-risk patient in the first place, then a CTG would be expected. So in those cases, then people end up scrutinizing the CTG. But again, the argument is often there is actually no evidence of direct evidence of hypoxia, but they speculate. The plaintiff's lawyers are speculating. There must have been, because look what's happened to the child. And there was this period of lack of monitoring. There was 2 hours where we don't know what the fetal heart. So there must have been. And anyway, it becomes a case of which team of lawyers has prepared better and can put a better case. And unfortunately, when the Department of Health is defending, sometimes it's like a school rugby team playing against the Springboks, and you know who's going to win because they just are not on the same level.
Okay, thank you.
Just on that point, yes, the CTG
Sabanjani?
might not be standard of care, but when you have lack of nurses to do the listening, and there's a prevalence problem. You have one nurse who's looking after 8 patients or whatever the story is. Where is she going to be able to listen to the fetal heart and document that? That's where our biggest challenge is, and that's why most of us have defaulted to a CTG. Because if you had a normal CTG, if you've got a normal CTG, and now if you look at the commercials one, the CTG now are electronically and digitally saved. And so every minute is there. So if you're going to be saying there was, and then there is a recording that says there wasn't, then you can argue until the cows come home. There is nothing like that. So the problem with our public sector, we don't have enough public and commercial. There's not enough nurses to be listening, and obviously everything is retrospective. You look, even if the blood pressure recording in the partogram, it's retrospective. You look at obviously the plotting of the contractions themselves. It's retrospective. There's nothing prospective about all that kind of thing. So that issue is going to remain a problem because we don't have nurse to patient ratio is not adequate in terms of that. So we'll still have to default on the monitor, although it does not improve, it increases the risk. But once we start speculating, there must be. If there's a CTG that's normal, you can't say there must be. What must be? It's not there. There's no evidence of CTG. So I know CTG is not standard in low-risk patients, and we all admit that. But without having the manpower to do the monitoring, you will not let spend on if there isn't, because everything is retrospective. That's been documented in the pattern most of the time.
Okay, thank you. Thanks, everyone. We've gone well over time. Thanks, Dr. Raghunandan. Have a good weekend.
Thank you.
Recording stopped.